Um, my name is Zeng Wang. I'm one of the neuromuscular neurologists here. Today's topic is about acute neuromuscular disease in the ICU. As we know, the most neuromuscular diseases are chronic. We see patients in the clinic, but occasional when we're on call, we get to see the patient in the ICU. So the patient in the ICU, they say patient's not moving, patient has respiratory failure, intubated, and for several days now, patient's still not moving. They ask a neurologist to see any other neurological conditions, especially it's a relatively young patient without other significant past medical history. So today's the objective is recognize the acute neuromuscular disease in the ICU. Hopefully after today's talk, so we will know how to diagnose and treat the neuromuscular diseases in the ICU. I have no disclosure for this talk. You talk about the acute neuromuscular disease in the ICU. Basically, there's two categories. The first one is the diseases leading to ICU admission. And the second one is the disease happened in the ICU after ICU admission. So the disease leading to ICU admission, including the Guillain-Barre syndrome and the Myasthenia gravis. That's the most two common ones. And others like inflammatory myopathy or like a polymyositis or some botulism are extremely rare. Personally, I have not seen such cases. In the ICU. The diseases happen after the ICU admission, and including the critical illness polyneuropathy and critical illness myopathy. Last week, our pediatric neuromuscular specialist, Dr. Amanda Rogers, gave a very good presentation and a detailed discussion about the Guillain-Barre syndrome and Myasthenia gravis. Today, I will focus on the second group as a critical illness polyneuropathy and a critical illness myopathy. Let's talk about the case first. When I was on call in September, the local ER called want to transfer a patient, 56 years old, with progressive muscle weakness. About 10 days ago, patient had a low fever and diarrhea and fatigue. So they're thinking possible the COVID, patient probably get a COVID, but the COVID test was negative. About 5 days ago, patient started having numbness tingling in his fingers and toes. 2 days ago, patient, as the numbness tingling is getting worse, also started to have weakness in his arms and legs. A day ago, patient's weakness getting much worse, and then unable to walk. In the meantime, patient developed urinary retention. Otherwise, patient has no trouble talking, chewing, swallows fine. There's no breathing issues. So the past medical history was on, just regular things like high blood pressure, hyperlipidemia. Giving patients, progressive weakness or called ascending weakness, we decided just, admit the patient to ICU directly. When patient get to the ICU, we examined the patient. Patient's cranial nerve was fine, and the muscle strength 3 of 5 in the upper extremities and 2 of 5 in the lower extremities. We could not get any reflexes. The patient's sensory actually that time was unremarkable. Even patient has a lot of numbness tingling. When you examine the patient, actually sensation was unremarkable. The outline patient had some other workup, including CT of the head was unremarkable. Patient had an MRI of the cervical and the thoracic spine. This is unremarkable. The patient even had a lumbar puncture, and the CSF study shows WBC 3, RBC 89, protein just borderline 43, glucose 60. So basically, it's unremarkable except the borderline protein. So we decided to give patient treatment and give patient IVIG for the working diagnosis of GBS, the Guillain-Barre syndrome. So the patient still getting worse every day. I took care of the patient for 3 days before I signed off. And the patient, on day 3, patient became quadriplegic. They could not move arms or legs. And also patients started to have bulbar palsy syndrome. So patient cannot talk very well and trouble swallowing. And of course, the patient's the breathing becomes very labor. And then the patient was intubated on day 3. And so we got the neural conduction study and the EMG the following day, and which shows severe axonal loss. So basically, you shock the nerve, you don't get any responses, especially the lower extremities. And the patient also had a MRI of the lumbar spine, which reported diffuse enhancement and the thickness of the intrathecal nerve roots, especially the anterior roots and especially the proximal segment. So the patient was diagnosed with acute motor axonal neuropathy. So we know it's a variant of GBS. GBS, it's the classic GBS or another called acute acute demyelinating acute inflammatory demyelinating polyneuropathy or AIDP, and it's an acute symmetric flaccid weakness. The proximal usually more severe than distal, and the lower extremities usually more severe than upper extremities. And some patients, about 1/3 of patients might have facial weakness, bulbar palsy, and respiratory failure, just like our patients. Most patients have sensory loss later on, especially the distal extremities, in the hand, in the legs, in the feet, and also the pain. Is some patients present with pain, especially back pain. It's kind of a typical presentation, and that's why some patients are sent back home a couple times from ER because just presented with sensory symptoms and back pain without significant muscle weakness. And when you examine the patients, the reflexes usually decrease or you could not get any reflexes. About 30% of patients need an ICU admission, and the patient eventually on intubation and mechanical ventilation. If you do EMG neurokinetic study, the typical GBS patient will show demyelinating features like prolonged latency, slow conductive velocity, and amplitude relatively normal. So you do spinal tap, the CSF study, the typical cases where shows aminocytologic dissociation, especially after 1 or 2 weeks, the CSF usually shows typical findings. There's several variants, like one is acute motor axonal neuropathy, just like our patient, and the second one is called acute motor sensory axonal neuropathy. Others are Miller-Fisher syndrome. The fourth one is rare. Sometimes you might see this, like a pharyngeal, cervical, brachial weakness with ptosis. That's basically, it's mainly affect the upper body. The typical classical GBS usually affect the lower body more than upper body. So admission to ICU, I would say about 30% of patient will be admitted to ICU. Usually, if a patient has respiratory insufficiency by clinical features, or you monitor respiratory function, especially like if FVC less than 15 or oxygen levels less than 70, patients need admitted ICU, patient may need intubation anytime. Another study shows if FVC drop 50%, the intubation required within 36 hours. And if FVC dropped to 1 liter, the intubation needed in 18 hours. And also the study shows the early intubation, the patient will have less complications. If you do emergency intubation, the patient always has more complications. So for GBS patients, especially like a progressive GBS, like we call ascending weakness, or patient has signs of Guillain-Barre palsy symptoms. Patient need admit ICU to monitor respiratory function, and the patient may need intubation anytime. Regarding treatment of GBS in the ICU, there's two major treatment. One is plasma exchange, another is IVIG. The clinical trials in 1980s shows plasma exchange was effective. It's patient recovering better and quicker than supportive care. In 1990s, there's clinical trials shows IVIG, they're equally effective as plasma exchange. And more study shows IVIG alone or plasma exchange alone, they equal to plasma exchanging plus IVIG. So they usually the patient just need one treatment, either IVIG or plasma exchange. But in practice, a lot of time, a patient end up to get two treatment, because patient after one treatment, patients clinically still getting worse, so the patient end up get another treatment. Our patients, after first IVIG, the patient and the family thought a little bit of improvement. So the patient and then getting worse, and the IVIG was repeated. And another second session of IVIG was given the following week. And then later on, after a couple of weeks, the patient had a plasma exchange. That patient still in hospital after ICU, staying ICU for a month, and then patient get a trachea and get a PEG tube, and then patient was transferred to Kendra Hospital, stayed there for a month. Recently, I checked the patient's record from the patients in the rehab, pressure rehab. Patient still has severe weakness, but otherwise respiratory function relatively stable. So another question is about the relapse. So as we know, the GBS usually is a monophasic. It's only like about 1% of patients might have relapse symptoms. So there's several studies try to figure out what's the chance of relapse. They use this group, so no treatment. Basically, the patients, the patients were used for clinical trial. Probably patients just get a placebo. There's no IVIG, no plasma exchange, and this group are 1% relapse. After get a plasma exchange, about 4% patients shows relapse. The main reason because other small group study looks like there's more patient shows relapse. Same thing, the IVIG treatment group, up to 10%. Also, I think it's because the small number patients. If you get rid of these two small groups, the relapse is still about 5% or 6%. Also, another group from the clinical trial, that shows the plasma exchange plus IVIG is about 7%. So overall, the relapse probably 1 to 5 or 6%. So the GBS is still most time is monophasic. Current guideline from the American Academy of Neurology. So this shows the plasma exchange is established as effective and should be offered to severe GBS patients. Same thing, IVIG is elective as and should be offered to treat GBS in adult, but probably they don't have much evidence for pediatric patients. Lately, there's a very detailed guidance in diagnosis of and the treatment of GBS, and it shows 10 steps approach to diagnosis and management of GBS. So basically, the patient, if patient presented with progressive sensory symptoms and weakness, and when you examine the patient, there's no reflexes, or patient some has a BOBA, start have BOBA symptoms, there's a high suspicion for GBS, and that should consider to admit to ICU if patient has any questionable respiratory status, and the treatment is IVIG and plasma exchange. In the meantime, you watch, you monitor the patient's complications. So another thing I want to mention, some patient, still shows recovery even after 3 years. So the patient with GBS patients, I usually tell patients, never give up till, the patients still have a chance to recover even after 3 or 4 years. This is a very good article for residents if somebody wants to read it. So this article in the Nature Review Neurology, so 2019. So another disease leading patient to ICU admission is Myasthenia gravis, and everybody knows Myasthenia gravis very well. It's usually a patient presented with fluctuating weakness or fatigue, especially ocular muscles. Patients have ptosis, double vision, blurred vision, and some patients have bulbous symptoms, dysarthria, dysphagia, or something, and then limb weakness. Basically, Myasthenia gravis affect the upper body more than lower body. The patient should not have any sensory complaints like numbness, tingling, or something. When you examine the patient's reflex is relatively normal, so that's different to GBS. About 30% of patients develop respiratory failure or called Myasthenia crisis. The trick factor including anything. The most common is surgeries. Lately I got a couple of patients, had Myasthenia crisis after shoulder surgery. Other things like any kind of infection, like pneumonia or UTI, or even like a stress can trigger Myasthenia crisis. How to diagnose Myasthenia gravis? We used to use the tensilon test. As it shows a picture here, the before tensilon and after tensilon, you can see the significant improvement. This is, you can tell, it's you feel comfortable to diagnose with Myasthenia gravis. Other tests for diagnosis including repetitive nervous stimulation. Amanda gave a very detailed explanation about repetitive nervous stimulation last week, so I'm not going to repeat it. Basically, in Myasthenia gravis, you will see called decrement. The amplitude become lower after repetitive stimulation the nerve. We call decrement. For another condition, as we know, is Lambert-Eaton syndrome. In that case, the amplitude actually increase after repetitive stimulation. Amplitude increase, we call increment. So, of course, for Myasthenia gravis, we check antibodies, especially anti-acetylcholine receptor antibody. You can see then the 50% ocular Myasthenia gravis patients, or 90% general relapsed myasthenia gravis patients will have the antibody. The second antibody is a masked antibody, about 5%. The third antibody, the LRP4, about 1%. Usually we don't check, I usually check anti-acetylcholine receptor antibody. If this come back negative, but clinically patient really sounds like a myasthenia gravis, I will check anti-masked antibody. That's for the diagnosis. The ICU, there's no large study about ICU admission, but basically any patients with a questionable respiratory status should be admitted to ICU, and due to frequent FVC or NIF measurement, basically it's a monitor respiratory function. Very similar to GBS. If the FVC less than 15 or NIFs less than 30, and the patient probably need intubation anytime. The early intubation or selective intubation still better than emergent intubation. That will reduce the pulmonary complications. Regarding treatment of myasthenia crisis, still two major treatments. One is IVIG, and another one is plasma exchange. The clinical trials shows IVIG and plasma exchange. So basically, there's no different. And some said the plasma exchange is slightly better than IVIG, and probably just the patient shows recovery improvement a little bit quicker than IVIG. Usually, after plasma exchange, you might see some improvement within like 2 or 3 days. IVIG take a little longer, up to a week. But the guideline, this is still the evidence. There's no strong evidence, no insufficient evidence to support or refute the use of plasma exchange. They just label you. That's for plasma exchange for the reason. But IVIG actually, it's this is probably effective and should be considered to treat moderate or severe myasthenia gravis, like a myasthenia crisis. I think the guideline become a little bit controversial. That's why in later on, after several years, they have a international consensus guidance for management of myasthenia gravis. So this is a very good article. I recommend all residents to read this. I will tell you how to, manage myasthenia gravis patients. Now here, I just give a little bit of summary of plasma exchange and IVIG in these two major treatments. The number one, plasma exchange and IVIG are used as a short-term in patients with myasthenia gravis with life-threatening signs, such as respiratory insufficiency or dysphagia. Basically, we call severe myasthenia exacerbation or crisis, or in preparation for surgeries. And, so we know some patients will need like thymectomy, and before thymectomy, especially in the patient who has vulvar symptoms, patient need IVIG, or for patient who need a rapid response to the treatment or any kind of like procedures like colonoscopy or something, you give patient IVIG before the procedure. Another condition is other treatment like medicine or other immunosuppressive agent not insufficient or not effective. You give IVIG or plasma exchange. Or some say, if you start a steroid, especially high dose of steroid, potentially make the symptoms worse, and say you might try plasma exchange or IVIG before starting a high dose of steroid. The choice between plasma exchange and IVIG depends on individual patient fact. if patient has sepsis, probably you don't want to give patient plasma exchange that causes contamination. If patient has a renal failure or heart failure, you don't want to give patient IVIG, or patient has a history of DVT or other, PE, or so you don't want to give patient IVIG because that's a significant increased risk of venous thrombosis. Or these two treatment depends availability of each. Now the most local small hospital can give patient IVIG, but they cannot do plasma exchange. So that depends on where the patient, which hospital patient has. So IVIG, this IVIG plasma exchanging is usually effective in treating severe generalized myasthenia gravis, but for mild or ocular myasthenia gravis, we usually don't give patient IVIG or plasma exchange. The plasma exchange may be more effective than IVIG in MuSK myasthenia gravis. That means, as we know, the MuSK myasthenia gravis, most of the patients will have bulbar symptoms. So if a patient bulbar symptoms, maybe you might consider plasma exchange before IVIG. So the IVIG can be used as a maintenance therapy for refractory myasthenia gravis. So we do this all the time. There's patient still have severe symptoms and patient needs IVIG monthly. We can do like the home infusion IVIG, but you cannot do plasma exchange in the every month. Usually we don't do that. You have to admit the patient to do that. So overall, this is a very good article. I recommend residents read the article. So now let's talk about another case. The patient was a 60-year-old lady with a history of COPD, presented to ER with severe COPD exacerbation. The patient needs intubation in the ER and started treatment of steroid or theophylline, and then patient admitted ICU. In the ICU, patient received several antibiotics for pneumonia because the X-ray shows possible pneumonia. Of course, in the ICU, patient was intubated on ventilation. Patient get the lorazepam and the Versed all time for sedation, and the patient also had a insulin sliding scale because the hyperglycemia after steroid treatment, and this patient didn't get any neuromuscular blocking agent. So the ICU, patient's ICU course was complicated by acute respiratory distress syndrome, and also the patient developed tension, pneumothorax. Patient required chest tube. Like most of the patients we see in the ICU, the patient has mental status changes. Asking neurology to see the patients, that's the acute encephalopathy with multifactorial. That's the patient has 100 reasons to have, mental status changes. The patient has metabolic reason and infection. Patient get a lot of sedation, and the patient had a difficult weaning from ventilation. Finally, patient shows improvement and activated in about a month. After activation, the final patient has severe muscle weakness and also muscle atrophy. They ask the neurologist to see the patient again, and the neuro examination shows muscle strength about 2 or 3 or 5 in the proximal muscles, and 0 to 2 or 5 the distal muscles. So basically, you can tell from the feet. Actation of it, that means there's no muscle strength in the lower extremities, and also shows the muscle wasting here. The patient was awake, and then could not do exam, and shows the sensory loss to all modalities below the forearm and below the knees. It's a typical, we call stocking, gloves stocking distribution of sensory loss. The patient didn't have any reflexes. Patient had a neurokinetic study which shows sensory model axonal peripheral polyneuropathy, especially in the low extremity. So basically, the low extremity, you do the neurokinetic study, and there's no any responses. So this patient had a nerve and a muscle biopsy. The muscle biopsy shows a kind of scatter angular muscle, degenerated muscle fibers we call neurogenic, and also nerve biopsy shows significantly reduced the nerve fibers. So this patient was diagnosed with critical ionized polyneuropathy. Actually, this is a very typical case of critical ionized polyneuropathy. So the disease is acute neuromuscular disease happen in the ICU, including critical ionized polyneuropathy and a critical ionized myopathy. I will spend later more time about these two conditions, discuss these two conditions. This is not a new concept. Actually, the first article published in early 1980s. There are 5 cases. The patient was admitted to ICU for lactate acidosis, emphysema, COPD, exacerbation, pneumonia, and one is head tremor. They found all of 5 patients developed neuropathy. Like the first case, that lasts for more than 24 months. The second case lasts for more than 10 months, then more than 3 months, more than 5 months, more than this one's 3 months. So more than 3 months, the patient, all patients developed neuropathy. They did a neurokinetic study, and the EMG on this patient shows. So basically, the conducting velocity and latency relatively normal or borderline, but the amplitude significantly reduced. They call axonal loss, the peripheral neuropathy with the axonal loss. They did a neural biopsy which shows a significant reduce of neural fibers. So the typical the CIP as the patient, the study shows the CIP is very common. There's more than 50% ICU patients, especially the patient has sepsis or some organ failure, will develop CIP. CIP also developed very early. The study shows like 3 days after sepsis, the patient already developed CIP, and some 5-6 days after ventilation, patient developed CIP. So it's very underdiagnosed. Probably this ICU team to monitor this condition since there's no special treatment. Overall, it's very underdiagnosed. The typical presentation of typical features of CIP is acute encephalopathy followed by difficult weaning from the ventilation. And then patient has some muscle weakness and atrophy in the arms, legs, especially the distal limbs. And the cranial nerve relatively remarkable. And the patient usually lost reflexes. The patient lost sensation. If you can do, the patient's relatively awake. If patient awake, you can do sensory exam. The patient find the sensory loss. If you do neurokinetic study, EMG shows the axonal neuropathy. So the one study shows actually, because a lot of patients have trouble weaning from the vent, so they did a study on phrenic nerve and the diaphragm muscle. The first study shows here they found the amplitude of phrenic nerve is extremely low. So basically, it's axonal loss of phrenic nerve. When stick a needle in the diaphragm shows the neuropathic changes. You can see the sharp waves and the fibs in the diaphragm muscle. Another study even more aggressive. They compared the normal of phrenic nerve to the patient phrenic nerve. You can see the amplitude significantly reduced. They even did the partial phrenic nerve biopsy, which shows significantly reduced of nerve fibers. So basically, the CIP patients, the phrenic nerve and the diaphragm are involved. So the diagnosis criteria, usually patient have, in the ICU, patient has a sepsis or other multi-organ failure or something. Then patients develop severe weakness, and some patients will have like a muscle atrophy, and the patients have trouble weaning from the vein. If you do the nerve connection, where it shows axonal neuropathy. So that's the diagnosis criteria. And in the older days, they do repetitive stimulation. Basically, they want to rule out the possibility of a neuromuscular junction disease like a Myasthenia gravis, something. So that's the CIP. There's another. In 1990s, they also noticed the ICU patient not develop critical illness polyneuropathy. Also, some patients, the sensation relatively normal, but the patients are very weak. They think about possible myopathy. Here's the study, the article published in 1996, shows acute myopathy of the ICU. The total have like 14 cases. They did a nerve conductivity study. The patients were like had a severe weakness. They did a nerve conductivity study. They found that the sensory nerve relatively normal. So that's make neuropathy less likely. And then the patients that went to the needle image, not only the distal muscle, also found abnormality in the proximal muscle. That's what they did a muscle biopsy. That shows the patient had a significantly myopathic changes. You see the muscle fiber necrosis, and some shows regeneration, and especially the type 2 fibers. And they did a EM shows some like a filament loss. So they think this is not neuropathic, so some myopathic. So they call critical illness myopathy, or CIM. They find the CIM is very common in ICU. At least like 1/3 of ICU patients are treated for status asthmatic or like a COPD exacerbation, and we developed CIM. And another study shows all 22 critical patients shows a clinical electrical diagnostic or muscle biopsy evidence of primarily myopathy. So this is very underdiagnosed too. The reason probably because there's no special treatment. I will talk about this later, and so that's why people did not pay attention too much. So also the one study shows actually CIM. It's a little more common than CIP. I will talk about this later. The typical clinical features of CIM including acute or subacute, diffuse, and flaccid weakness after ICU admission. They involve all limbs, especially the proximal muscles. Not like a CIP, it's a distal muscle. This is the proximal muscle more severe than distal, and relatively symmetric. Also, the neck muscle were involved. Neck, facial, or sometimes even ocular muscle might be involved too. And most of patients have diaphragm paralysis, so that's the reason patient cannot win from the ventilation. If patients awake, you will find that the sensation relatively normal, so that's different to CIP. Also, reflexes could be normal and could be slightly decreased. It's not like a CIP, it's a reflexia in all limbs. Some patient even shows elevated CK, but 50% of cases elevated CK. If you do the nerve conduct study EMG, which shows some myopathic features. So basically, the nerve conduct study, as I mentioned earlier, it's relatively normal or some borderline findings. The needle EMG will show significant myopathic changes. So the one study in 2011, basically this is a very aggressive study. The study phrenic nerve, needle EMG of diaphragm muscle, or did a muscle biopsy in the diaphragm. I don't know if this kind of study can be done. So the phrenic nerve shows here the amplitude relatively normal, but the needle EMG shows some myopathic changes. It shows a low amplitude and the improvement, recruitment increase. That's what we call myopathic changes. The muscle biopsy of the diaphragm muscle shows myopathic changes. It shows here degenerative muscle fibers. The EM also shows filament, thick filament loss here. So if you don't do diaphragm muscle, you do other skeletal muscle, also shows very similar findings, like a degenerative muscle fibers here, especially the type 2 muscle. Here's the ATPS pH 9.4. It usually shows a dark staining. It's a type 2 muscle fiber that shows significantly reduced. The EM shows, as I mentioned earlier, the thick filament loss. This is a relatively normal. It's a normal. This you can see that significantly reduce the number of thick filament. So diagnosis criteria for CIM, the ICU patient, especially patient has multi-organ failure or some like or other treatment in the ICU, and then the patient developed the muscle weakness, the flaccid weakness, as I mentioned earlier. If you do the neurokinetic study, it's relatively normal or slightly reduced amplitude or something. But the needle EMG will show some myopathic changes. So you have, of course, you always rule out other possibilities. The muscle biopsy, neural biopsy is optional. There's some so because since we're now changing the management, we can do clinical diagnosis. These two conditions, CIM and CIP. So basically, the CIM, the risk factor including like a steroid or other neuromuscular junction blockers. CIP, they get sepsis or multi-organ failure. Basically, this risk factor you cannot tell which one causes which. They usually cause both conditions. But the clinical features are a little bit different. In CIM, of course, the patient has a pure motor deficit, pure muscle weakness. But in CIP, patient has sensory loss. CK is maybe elevated 50% of case, but usually it's normal in CIP. Nerve conduct study is relatively normal in CIM, and we show axonal loss in the CIP. Needle EMG, we show some myopathic here and the neuropathic here in CIP. The pathology, we usually don't do biopsy, but if you really want to do biopsy, we'll see the muscle called myopathic changes, muscle fiber degeneration, and the myosin loss. This shows neuropathic changes. Recovery, this critical illness myopathy a little bit better than critical illness polyneuropathy. So this one's slow, take weeks or months. This take much longer, a month or even years. Then we talk about these two conditions. Actually, a lot of time, these two conditions coexist. The study shows CIM and CIP are frequently found in combination. So that's they call critical illness polyneuropathy and myopathy, called CIP-NM. So there's several studies. The first study was done in 1996, and it shows totally 14 patients And the 14 patients found that all of them shows myopathy, but 8 of 22 patients shows evidence of neuropathy. So a lot of times there's a combination. The another study shows 10 patients with the CIP. Actually, the muscle biopsy in all the 10 patients found that all of them have some myopathic features. So the two conditions coexist in most cases. Risk factor. There's many studies try to figure out what kind of risk factor. This is a very busy slide, so I'm do this a little bit of summary here. Basically, anything happening in the ICU could be risk factor. There's no special ones. You can see they included like sepsis, multi-organ failure, or systemic inflammatory response syndrome, or other like a long duration organ failure, or some like renal failure with dialysis, extended ICU stay, nutrition, the total parenteral nutrition, or osmolality changes, hyperglycemia. The treatment, the medication includes steroid, neuromuscular blocking agent, or some vasopressor, or even antibiotics. Of course, the elderly patients has more chance to develop these two conditions, and that shows a female patient a little more common. So basically, anything happening in ICU could be risk factor. Pathogenesis, still don't know. There's some theory like this could be vascular, especially microvascular conditions, like including hypoxemia, or some metabolic reason, or even electrical alteration. There's some like a channel dysfunction. So basically, we still don't know the cause. We don't know pathogenesis. That's the theory. Since these two conditions are very common, so there's several studies, try to find the treatment. Since IVIG works for Guillain-Barre syndrome or another condition, as we know, the CIDP, chronic inflammatory demyelinating polyneuropathy, or CIDP. So they try to use IVIG for critical illness polyneuropathy. The clinical trials was done in 1994. Failed. Basically, there's no difference. And several years later, in 2013, they tried to use like IgM enriched IVIG. Basically, still shows does not mitigate the condition either. So basically, IVIG is not effective. I have not seen the study about the plasma exchange, but at least IVIG is not effective. The second study is about intensive insulin treatment. This study published in the New England Journal of Medicine. Sorry, I think it's some. Okay. So they published the New England Journal of Medicine was done in 2001. There's two groups. One is use the conventional insulin dose. Another group use high dose insulin dose, and keep the conventional treatment group keep insulin, about 150. The intensive insulin treatment group can keep the blood sugar so about 100. This shows the intensive insulin treatment group patient survival better, as it shows here. Also, the number of deaths less. The most important, they did the neuromuscular study EMG shows the 51% patient in conventional insulin treatment developed neuropathy. But in intensive insulin treatment, only 28% of patients developed neuropathy. So the conclusion is that intensive insulin therapy to maintain blood glucose at or below 110 can significantly reduce development of CIPAM. This can. Another study that shows electrical muscle stimulation. It's a direct stimulation of the muscles. That shows one is treatment group, another is non-treatment group. They found that the treated group shows muscle strength is better than untreated the control group. Also, the development of CIPAM in treatment group is only 12%. The untreatment group, control group, are almost 40%. So that's a significant difference. So the patient stay in ICU shorter and also stay on ventilation relatively shorter. So this study, they say, the electrical muscle stimulation could reduce the CIPAM. The early physical therapy might work, but there's no clinical trial. That's I think probably it's difficult to do clinical trial in this case. But we, all the physical therapy, it's all time try to get a physical therapy as early as possible. That's probably significantly reduce the development of CIP or CIM. So if anything else we can do, they say, this patient shows here, like patients not moving for more than 10 days, and there's anything else, we can prevent the ICU-related weakness. So obviously, the more study is needed. So number one, we don't know, the pathogenesis. Of course, the treatment is not as specific. Hopefully, there's more studies, be done, find the specific treatment for these two very common conditions. Prognosis, there are several studies. This very busy slides, but the summary for this. The prognosis basically the spontaneous recovery can happen within weeks in mild cases. The severe cases will take many months. Complete recovery can happen in 50% of patients, but still 1/3 of patients remain severely disabled after ICU admission. The one reliable predictor is nerve conduction study. If nerve conduction study shows unrecordable, the motor response or CMAP, usually indicated the severe functional disability for a long time. Usually up to 5 years, the patient, if survivor patients, if we do nerve conduction, still shows abnormalities. Very good. So today we talk about the acute neuromuscular disease in the ICU. Basically, the two groups. One group like Myasthenia gravis or Guillain-Barre, leading patient to the ICU admission, and critical illness, polyneuropathy and critical illness myopathy can happen in the ICU. These two conditions are actually are very common, and right now we still don't know too much about pathogenesis. There's still no specific treatment. The study shows probably intensive insulin therapy keep low normal of blood sugar, maybe reduce the development of CIP and CIM. Also, direct electrical stimulation of muscles might reduce development of these two conditions. I think I'm stop here. I'm happy to answer some questions. Okay. Thank you. Looks like sounds like no questions. Thank you. Have a good day.
Thank you, Dr. Wang.
Thank you.